moderators for this meeting, and my discussant, Dr. Vishwajit Majumdar, all are there. So we start with the case. Dr. Ratul Ghosh and Dr.
Good afternoon,
Somnath
sir.
Maji. Yes, yes,
Am I audible, sir?
yes.
Yes, sir. Good afternoon, sir.
Good afternoon.
Sir, I think there is some technical issue with Dr. Somnath. He cannot just listen to he just texted me. So I would request the tech team to kindly look into it.
Sir, his audio not connected. His audio not connected.
His audio is not connected.
Not connected, sir.
So I should I tell him to rejoin again?
Yes, sir. Yes, sir.
Okay, just give me a moment. I will give him a call. Just a moment. Yes, sir.
Yes.
So sorry for
Now
the
it's
interruption,
connected.
sir.
Now it's connected.
Yes.
Hello, Ratul.
Yes, sir. I'm here, sir. Shall I start, sir?
Yes, yes, start. On your video first.
Thank you, sir.
Switch on your video.
Yes, sir. My video is not visible, sir.
No.
Oh, but in my screen it is showing the video.
Just follow the instruction of our technical team. Kishorji, can you please just guide him?
No, actually, sir, kindly, there is a button to your camera. Just click that. I can see your UCam 5.
Yes, but there is no button in my camera. Just
You are using external camera or?
no. It's inbuilt in my laptop.
Okay, side you can see button, sir. Top center, there should be a button. Just swipe left or right.
Oh,
In top center,
yes.
there is
In
a
my
camera
laptop
icon.
panel.
Yeah, in laptop panel, not in Zoom. In
Oh
laptop
no.
panel.
a resident of Kolkata. He is grocery shop owner by profession. He was admitted with chief complaints of shortness of breath on exertion for 6 years and chest pain on exertion for 3 years. He was apparently well 6 years ago when he developed shortness of breath on exertion, which was gradual in onset and progressive in nature. Initially, he experienced shortness of breath only on exertion, that is, while walking towards his shop at a hurried pace, lifting more than 10 kilograms of sacks, climbing up more than 2 flights of stairs at a stretch, which gradually progressed to a level in which he became breathless while going to his shop, which is situated adjacent to his house, weighing and selling groceries. Breathlessness relieved after taking rest. He visited local physician who told him about some heart disease and prescribed medication, taking which his symptoms improved so that he could run his shop. He couldn't mention the name of those medications. After discontinuing medication on his own, symptoms deteriorated and he became breathless, performing regular day-to-day household and personal activities. There was no history suggestive of orthopnea or paroxysmal nocturnal dyspnea. There was no history of cough, fever, seasonal exacerbation or diurnal exacerbation or wheeze. 3 years ago, he started having chest pain, which was retrosternal in location and compressive in nature. Chest pain increased after exertion and often after heavy meals, relieved after taking rest. He used to take one medication sublingually, but pain did not improve. There was no radiation, no sweating, no palpitation, no syncope or presyncope. There was no history of any pedal swelling, abdominal pain, bluish discoloration of lips, mucous membrane or extremities, hemoptysis or hoarseness of voice, fever, joint pain or any skin lesion. He has no history of type 2 diabetes mellitus, hypertension. He has no history suggestive of rheumatic fever in childhood. He is non-smoker, non-alcoholic. He has one brother, no similar history or illness or history of sudden cardiac death in his family, brother or parents. He is born out of non-consanguineous marriage. So to summarize, a 46-year-old non-diabetic, non-hypertensive gentleman was admitted with exertional breathlessness for 6 years, exertional chest pain for 3 years. Exertional breathlessness was initially of NOH class 1, which gradually progressed to NOH class 2. There was no history of orthopnea or paroxysmal nocturnal dyspnea. Exertional chest pain was retrosternal, compressive in nature. It was aggravated on exertion and after heavy meals. There was no history of suggestive or rheumatic fever in childhood. There was no significant past or family history.
So, what are the possibilities at this stage?
Sir, I have two chief complaints. One is shortness of breath on exertion, and another one is chest pain, or that is angina. So dyspnea on exertion for 6 years and angina for 3 years. So taking those two into account, and also there is no history of any respiratory significant symptoms. So this shortness of breath probably is attributable to cardiovascular etiology. So among the mechanisms by which cardiovascular diseases can cause shortness of breath, that is pulmonary venous hypertension, left right shunt, cyanosis, and low output state. Regarding the history and all the negative histories, pulmonary venous hypertension is most likely underlying mechanism for the shortness of breath on exertion. And at 46 years of age, along with angina and pulmonary venous hypertension, probably it is due to increased LV-EDP. So, sir, according to preference, my differentials would be left ventricular outflow tract obstruction, either in the form of valvular heart disease or subvalvular obstruction in the form of hypertrophic cardiomyopathy. Ischemic heart disease will be my second DD because angina appeared late. Pulmonary hypertension and RV outflow obstruction is another possibility, taking into account the dyspnea and chest pain, sir.
So,
So you do think the chest
Yes.
pain is anginal pain?
Sir, the character is typical, the retrosternal compressive, but it is not typical angina because it did not improve with taking nitrates.
Yeah, they didn't improve
It is
taking
atypical chest
nitrate and
pain,
no.
sir.
Yeah, so you cannot say this angina. So from this history, he is 46-year-old and presenting for the first time at the age of 40 and gradually progressive breathlessness.
Yes, sir.
What other differential diagnosis will come up?
Sir.
Is it
What other reading you want
differential?
to?
So you are thinking this may be LVOT obstruction, number one.
Yes, sir.
Yes.
So why are you thinking? Because you see, there is no syncope, no pre-syncope, nothing is there. Why you are thinking of LVOT obstruction?
Sir, I am putting LVOT obstruction as my first differential diagnosis, taking into account dyspnea on exertion along with chest pain.
Yeah.
Yes, sir.
No. What you are saying it is right. Dyspnea on exertion and chest pain is only one diagnosis. This is
No,
LVOT
sir.
obstruction.
No, sir. No, sir.
It's a
No,
very
sir.
common in angina. It's
No,
very common in CAD.
Sir, very common. And also in case of accelerated hypertension in our outdoor patients, we do get this
So
kind of symptoms,
hypertensive
and it
heart,
is very common.
yes,
Yes,
correct.
In
sir.
a normal
Hypertensive heart is
CAD
one of the
patient,
Yes.
Yes,
in a
sir.
normal CAD patient, the history is typical angina and dyspnea.
Yes,
So
sir.
why
Exactly.
you are pinpointing the diagnosis as Dr. Saab is
LVOT
asking, there's no pre-syncope, there's nothing to LVOT obstruction. How you are keeping it as a first differential diagnosis based on history? And
You got the point.
second important thing, he may be having an angina typical. You say nitrates is not relieving. What
Yes, sir.
happened in LVOT obstruction in an angina when you give a nitrate?
Sir, it may increase, sir.
Kyo, yes. So
Yes.
there's an exception. It's always not true.
Yes, sir.
If it is not relieved by the nitrate, what may be the mechanism?
So nitrate causes vasodilatation, which
No.
increases the gradient.
Suppose there's a 99% stenosis that is a plaque, in that you cannot do a vasodilatation.
Yes, sir. Yes, sir. In that case,
So it will
the
remain
angina will not improve.
99%.
Yes, sir.
Tell me, if there's no vasoconstrictive component, then the nitrate is not going to help.
No,
What
sir.
will happen in an LVOT in AS when there's a fixed obstruction in coronary artery disease? If you give nitrate, the angina will worsen or it will improve.
Sir, in case of fixed obstruction, if we give nitrates, sir, it will not improve, sir.
What may be the other side effect of giving nitrate in HOCM?
Sir, because of vasodilatation, the gradient may increase, sir.
Yes.
Yes, gradient will increase because
Yes,
there is
sir.
not only that, your preload will decrease and afterload will decrease. There is further.
Exacerbates the symptoms, sir.
Yes,
It
yes,
aggravates the
okay.
symptoms.
So I think in my view, ischemic heart disease or hypertensive heart disease should as number one.
Yes,
Differential
sir.
like LVOT,
Sir,
unless there is
sir, I have not taken hypertensive heart disease because he has consulted doctor multiple times and every time he came out to be normotensive, sir.
okay.
Yes, sir.
So, these symptoms are very relevant for ischemic heart disease. We are putting as number 2.
Sir,
History is suggestive of ischemic heart disease.
sir, history may corroborate with ischemic heart disease, sir.
How? He has
Sir,
dyspnea on exertion for 6 years.
yes, sir. Because angina
Chest pain
occurring
for 3 years only.
as this contraindicating. In case of ischemic heart disease, the chest pain and shortness of breath should come in hand in hand, or maybe angina may precede shortness of breath.
Exactly.
Yes, sir.
Then
that sometimes shortness of breath may be angina equivalent. We do not know.
Yes, sir.
In our country where ischemic heart is so common and people having ischemic heart disease young, we cannot just rule out from the symptom that it may not be. Maybe
Yes,
your
sir.
drag, yes. And chances of LVOT obstruction, you see the frequency, you see the incidence, you see the which is more common.
So ischemic heart disease definitely, sir.
Yes.
Yes, sir.
Okay, sir. This is only history. He have to say
yes, you can go
why
ahead.
this and why not. Okay. So can it be pulmonary hypertension number 1?
The pulmonary hypertension number 1, So dyspnea, angina, pulmonary hypertension, sir, it is in the absence of secondary etiologies, it is rare. Rarer than ischemic heart disease or sir LVOT obstruction.
Pulmonary hypertension means you mean primary.
Yes, sir, primary. In the absence of other
Primary.
secondary etiologies.
Is it the classical presentation? The
No, sir.
primary pulmonary hypertension. Nowadays we call it idiopathic pulmonary
Ah,
hypertension.
yes, sir. Yes, sir.
Yes. Is it a common presentation?
No, sir.
Then
So what will the presentation in pulmonary hypertension?
Sir,
idiopathic
fatigue. Sir,
pulmonary
fatigability.
hypertension.
Sir, fatigability is predominant presentation initially, sir. Patients comes with fatigue.
Occurs more in male or female.
The female.
Then
Yes, sir.
So can it be mitral stenosis?
yes,
Simple.
inflow obstruction.
Sir, LV inflow obstruction, sir, symptoms may corroborate, but usually in case of LV inflow obstruction, we get orthopnea or paroxysmal nocturnal dyspnea, in particularly when the patient has progressed to NOH class 3. It is expected, not always, sir, but it is expected.
Okay, okay.
Can you explain that angina and mitral stenosis?
Sir, yes, sir, angina can occur in mitral stenosis, sir. One is because of right ventricular hypertrophy. Another is that when pulmonary hypertension develops, it may compress the left main artery. And another is that mitral stenosis with coexisting coronary artery disease.
Very unusual. Mitral stenosis.
Yeah,
is not very
unusual,
common.
unusual.
And if it is,
Yes, yes.
if it is present, that is because of severe PH, RV, or
Yes,
RV hypertrophy.
Yeah.
Pulmonary artery dilatation usually does not occur so much in MS. It
Yes,
can
sir.
occur in ASD patient.
Yes, sir. Yes,
In
sir.
ASD, sometimes some cases are there.
Hmm.
Dilated pulmonary artery can compress the left main. But
Yes, sir.
MS back pressure pulmonary artery is not usually dilated.
Yes, sir.
So even just the question that was asked, by natural history, can you differentiate pulmonary arterial hypertension who presents with breathlessness and angina, and your hypertrophic cardiomyopathy and ischemic heart disease? What is the natural history of all these three diseases? Natural history is not same.
No, sir. Sir,
Your
in case of-
duration,
yes, sir. Duration is very long. Sinus of the duration is very long for 6 years, and chest pain is for 3 years. Pulmonary hypertension usually comes with fatigue, and in case of such long duration, it will come with that.
pulmonary arterial hypertension.
Yes, sir.
If it is, you have said aortic
Yes, yes.
stenosis
Pulmonary
valvular,
arterial
na?
hypertension usually
In such long duration, it will culminate into right heart failure, sir.
I think main thing is that in his case, the complaints are very so common with all
Yes.
type of cardiac problem. They will be difficult to pinpoint a particular problem. They are slowly progressive
Yes,
over
sir.
6 years, and first dyspnea and then exertion or chest pain on exertion. It's difficult to point out anything, but we'll have to discuss the differential diagnosis. He has discussed. I think we'll move forward.
Yes. But RVOT obstruction, where have you kept?
Oh yes, RVOT obstruction. Yeah.
Sir,
Because
in case of some cases of valvular PS, sir, there may be, despite fatigability, there may be chest pain and also shortness of breath.
this is less likely because
Less
at the
likely,
same
sir,
time,
yes.
you see, somebody will ask definitely. At the same time, you will keep LVOT obstruction and RVOT obstruction. That is very difficult to digest again.
Yes.
Okay.
Okay. Proceed.
Yes, sir.
Yeah, proceed.
Yes, sir. So, coming to general survey, patient is alert, conscious, cooperative, oriented to time, place, and person. Faces is normal, build average, nutrition is good, decubitus is of choice. There is no pallor, cyanosis, icterus, clubbing, or edema. Height 176 centimeter, weight 70 kilogram, BMI 22.6 kilogram per meter square, arm span 177 centimeter. No neck gland is palpable. His blood pressure was 138/78 in right upper limb, 136/80 in left upper limb supine position. Pulse 72 per minute, regular, normal volume with rapid upstroke, experience in character. All peripheral pulses are equally palpable. No radioradial or radiofemoral delay. Jugular venous JVP, jugular venous pressure is not elevated, waveforms are normal, respiratory rate was 16 per minute, abdominothoracic in nature, saturation is 98% in all 4 limbs.
Right. Then
So coming to cardiovascular system examination, on inspection, chest is symmetrical with no bulge, and impulse is visible in precordium at left fifth intercostal space near left midclavicular line. There are no other pulsation, scar or sinus. On palpation, trachea is central in position. Apex beat is felt at left fifth intercostal space at left midclavicular line. It is forceful, well sustained. Another presystolic impulse is felt at apical region. No thrill is palpable at apex. A systolic thrill is palpable at left third intercostal space, parasternal area. On auscultation, first heart sound is normal. Second heart sound is normal intensity with normal split. Third heart sound is absent. Fourth heart sound is audible at apex. No added sound are present. One harsh, high-pitched, mid-systolic crescendo decrescendo murmur is audible. Bass third as left third parasternal area with diaphragm of stethoscope with no radiation. Grade is 4/6. Murmur increased in intensity on standing and valsalva and decreased with hand grip and squatting. No other murmurs are audible.
right.
Yeah.
What
You
is
can
the
summarize
origin?
your findings.
Yes.
Sir, on sir, positive findings only, sir.
Yes, yes.
Yes.
So, sir, on general survey, I have found pulse to be of brisk rise along with bispherians character, and on palpation, there was on inspection there was an apical impulse visible. On palpation, apex beat is forceful, well sustained with double beating apex with one presystolic impulse. A systolic thrill is palpable at left third intercostal parasternal area. All the heart sound are normal along with audible fourth heart sound. One harsh high pitched mid systolic crescendo decrescendo murmur is audible at left third intercostal area parasternal region with diaphragm of stethoscope with no radiation of grade 4/6, increasing on intensity on standing and valsalva and decreasing in intensity with hand grip and squatting.
From the pulse, what you can think? The pulse you described,
Yes, sir.
this is
Sir,
because
rapid upstroke.
upstroke with bispherians character.
Yes,
So
sir.
what are the possibilities from pulse itself?
So rapid upstroke with bispherians in character. First is severe AR with moderate aortic stenosis. That's a hypertrophic obstructive cardiomyopathy.
Yes.
Right. Why did you feel pulses experience?
Sir,
How did you feel it?
sir, there are two peaks, both palpable in systole.
Yeah, that is.
How did you feel?
Sir, can you carotid it, sir?
Carotids, yes,
Yes,
single
sir.
arteries.
Yes, sir.
Right. Right.
Okay. Then, because what you described from your findings, almost one can reach a diagnosis. So we come back to your auscultation. So just
Yes, sir.
because you see this pulse is quite suggestive, and your apex, which double apical impulse.
Yes, sir. Double apical impulse. Yes, sir.
Yeah, and its apical impulse is forceful and well sustained.
Yes, sir.
Yeah, and this murmur, there only one murmur.
Yes, sir. One murmur is audible, sir.
So that
Other murmurs you expect?
Sir.
You searched. What other murmurs you
Sir,
expect?
sir, in this case, one hollow systolic murmur may be expected on mid to late systolic murmur may be expected at apical area, sir.
Any other?
And sir, one, sir,
That is due to?
sir,
that is
there is
due
no mitral regurgitation, sir.
Right. Then
And sir, one, in case of if the mitral regurgitation is severe variety, then one functional diastolic murmur may also be audible at apical area.
that due to this hypertrophic cardiomyopathy, murmur is not that severe to produce diastolic murmur, right?
Yes, sir. Yes, sir.
Yeah.
Yes, sir.
Suppose in this murmur, your systolic murmur, loud A2.
Yes, sir.
What are the possibilities?
Yes. From this murmur, what this grade 4 murmur based out in the third intercostal space and with this change in, I mean, dynamic auscultation, what are the possibilities?
Sir, in this dynamic auscultation is quite similar with mitral valve prolapse, sir, MVP.
Why?
But difference is that, sir, in case of mitral valve prolapse murmur, the murmur will lengthen, not will increase in intensity.
So mitral valve prolapse, there is no click here.
Yes, sir.
The click will come earlier and murmur will be
Follow.
prolonged.
Yes, sir.
Yeah.
The-
But
Multiple also, yes.
so you do not have now, you have only ejection systolic murmur. You
Yes,
have
sir.
no pansystolic murmur.
No, sir.
So you'll have to differentiate from aortic stenosis with dynamic LVOT obstruction.
Yes, sir.
Right.
So what will happen with aortic stenosis and what will happen with this and what has happened in your case? So
Sir.
how will you? Yes.
Sir, had it been aortic stenosis, first, sir, location will be in right second intercostal space. I am getting murmur at left third intercostal space. Another is, sir, if had it been aortic stenosis murmur, there should have been radiation to carotids, but here there is no radiation to carotids. And sir, aortic stenosis murmur will reduce in intensity with Valsalva maneuver. And but in this case, this murmur is increasing on intensity on standing and Valsalva, sir.
Um,
So what will be the changes? If it is a subvalvular membrane, aortic membrane, subvalvular membrane.
Subvalvular membrane, yes, sir. Sir, in case of subvalvular membrane, sir, it is in many times it is associated with aortic regurgitation. So, sir, cardiomegaly or sir, diastolic murmur
Not
is
always,
expected.
yes.
Not always, sir, but
Yes.
often frequent, sir.
What will be the character of the murmur and how to differentiate it from this HOCM murmur?
Sir, in case of subaortic membrane murmur, these classical dynamic auscultation features will be absent. That is,
And
and sir,
location of the murmur?
sir,
And
location.
yes, will be lower down and there will
Lower
be
down.
associated. There can be associated aortic regurgitation also,
Yes, sir.
regurgitant murmur present in about 50%
right,
of patients.
Yes,
yes.
sir.
So from say what will happen with aortic stenosis murmur if with squatting and hand grip?
Sir, in squatting and hand grip, sir, aortic stenosis murmur will also decrease.
Yes. So what you are telling me, Valsalva, this which phase of Valsalva you are telling?
Exactly.
Sir, it is straining phase, sir, phase 2.
Can I ask her 2 questions?
Yes.
Yes,
Yes. We are waiting.
You have written high pitch murmur.
Yes, sir.
How high pitch murmur can be a harsh murmur?
Yes, sir. High pitch murmur.
No.
If
No,
it is
sir.
high
What is the
pitch,
murmur of any stenotic lesion?
Should not
It's
be
high
harsh.
pitch. It may be harsh.
Yes,
It's
sir.
never high pitch. Either you say mixed pitch.
Yes, sir.
The high pitch murmur is only for regurgitant lesion, basically.
Exactly.
Okay, sir. Okay, sir.
So never write in your exam, it's a harsh mixed pitch. Then the examiner will never ask.
Okay, sir. Okay, sir. Okay, sir.
Second important thing, you have written mid-systolic crescendo
Mid-systolic.
decrescendo murmur.
Yes, sir.
So what is the peaking of the murmur? That is very important.
Sir, late peaking, sir.
Now you are in a trouble. It's a
Yes. Now we are in trouble. Yes.
Sir,
it is a
late peaking murmur, sir.
So
late
and-
late peaking murmur. And ending where? So for
Sir?
a murmur, you have to describe 8 characters, na?
Yes, sir.
So starting, peaking,
And ending.
character, and where it ends.
Yes, sir.
Where it ends.
So starting in mid systole, peaking in late systole, and ending before S2.
it's ending
It is
before
ending
Before
before
S2. Second heart sound.
A2.
Yes, sir.
So if it is late peaking, How can you correlate with pulses experience?
तुमने पल्स क्या बोली थी? What you have told the pulse?
Sir, rapid upstroke with Bispherians character, sir.
हाँ, तो
Right.
Bispherians pulse में वही मैंने तुमसे कहा you are in trouble.
Yes, sir.
How Bispherians pulse may be late peaking. It may be early peak. There may be two
Yes.
peaks, na?
Two peaks,
Right.
sir. Yes, yes, yes.
So it can never be a late peaking.
Yes, sir.
So these are the few important things which you should never express in your examination, because these are because they will ask, then you don't know what is a Bispherians pulse.
Exactly.
Okay, sir. Okay, sir. Okay, sir.
ठीक है?
Yes, sir. Yes, sir.
Right.
The S2 is absolutely normal. There is a normal split and everything is normal.
Yes, sir.
If suppose you have a paradoxical split of S2,
Yes, sir.
it goes in favor of fixed obstruction or dynamic obstruction.
Sir, paradoxical split, sir, you traditionally goes for severe fixed obstruction, sir.
Yes. Okay, correct. It usually goes for a severe fixed obstruction.
Yes, sir.
Now, what is paradoxical split? Tell me. The second
Sir.
heart sound.
Yes, sir. Usually on expiration there is a single second heart sound, and in inspiration there will be two components of second heart sound. In paradoxical split, sir, in expiration we will hear two sounds, and in inspiration we will hear one sound.
Suppose it is associated with AS is associated with ASD,
Okay, sir.
or there is a right bundle branch block in which is a wide split. Then how will you comment upon paradoxical split?
Aortic stenosis with
ASD.
yes, sir.
Huh?
In sir,
Because
ASD,
once, very good, you can answer it. There may be two things: right
sir.
bundle branch block, which is leading to the wide variable split,
Okay, sir.
and a
Yes,
wide fixed split.
yes, sir.
So in which if there is a severe AS, what will happen to second heart sound?
Sir, in case of atrial septal defect with ASD, as there is also widened hangout interval in pulmonary bed, and also there is prolonged ejection time and hangout interval in aortic bed, there may be a single second heart sound.
So single line, the second heart sound may be
Close,
Sir,
close.
close, sir.
Very good.
but
Very-
close. But fixity will remain, but it may be close.
Yes, sir.
Chalo, good. You are very close to the answer. Good. Continue.
A difficult question you asked, actually.
Then if they know the basic
Yes.
mechanism, they will answer. He has answered it.
Yeah.
The A2
Yes.
will be prolonged and P2 is prolonged, so it will be a narrower split.
Narrow
it will be
split, sir.
fixed. You cannot have a wide variable. It will be fixed,
Yes, sir.
but it will be narrow. Good.
Narrow and fixity remains. Okay.
Right.
Acha.
You are absolute.
Because it's so minimal findings, we are unable to bring other differential diagnosis here.
So what is the final diagnosis? Then we will ask, sir.
Yes.
Okay, sir.
So what differential he has got after this? Oh yes, continue.
Oh, sir. So my provisional diagnosis is it is a case of dynamic LVAT obstruction due to hypertrophic obstructive cardiomyopathy, currently in sinus rhythm, with no evidence of pulmonary arterial hypertension, no features of infective endocarditis, and in NOHA class 3.
Okay.
Why
No, he is
it
class 3.
Yes, you-
What class 3?
What is class?
Yeah, what do you mean by class 3? Class
Ah.
3.
So NOHA class 3 means, sir, a patient with existing heart disease has marked limitation of his physical activity, and he is breathless in less than ordinary activity.
Oh,
Sir,
Okay. You know, any other method to express like a specific activity scale and other?
So in chest pain, there is CCS scale.
Here, specific activity scale.
Yes, sir. It is.
YHA has got so many drawbacks.
Yes, sir.
We will discuss another day. That's
Yes,
why
sir.
specific scale has come. And Dr. Rautra is wanting
Yeah,
what should be the specific activity scale in this
Okay.
case.
in this case.
Okay, sir. Okay, sir.
But you have commented class 3 dyspnea, but no PVH. If there's no PH, no PVH.
Yes.
How can it is possible?
Exactly. That is
The PVH is there.
Class 3 dyspnea, what is the mechanism of dyspnea?
Sir, pulmonary venous hypertension, sir.
So there has to be pulmonary venous hypertension.
Yes, sir.
So no pH.
Yeah.
How can you say no pH?
The arterial hypertension features are
In
The
a
venous
form of
hyper-
what?
the venous hypertension is there, sir.
Yes. The patient may have a PVH,
Yes, sir.
but clinically you are not finding pH. How? Why? What is a mild, moderate, severe pH on clinical examination?
Sir, first of all, we can grade it with left lower sternal parasternal lift.
No. First is first. First is not left parasternal. First is second heart sound. Tell me about second heart sound.
Okay, sir. First, in case of pH, we may get loud P2. First, P2 is really louder than A2 in aortic area, and P2 will be audible in other areas than pulmonary areas.
No. What is mild, moderate, and severe pH according to P2 auscultation? It is not a definition. What is a mild? What is a mild? What is a moderate? What is a severe?
You see the where it is hard and compared to aortic sound. So
Yes, sir.
tell.
In
Define properly.
sir, in loud P2 is, sir, one in pulmonary area, P2 will be
Yes.
louder than A2, and
No.
P,
What is normal?
so normally P2 is softer than A2.
तो soft is no pH. तो loud क्यों
Yes, sir.
बोला तुमने? Next step क्या होगा?
Sir, equal to A2.
हाँ, तो बोलो when it is equal to A2, it
Okay,
is
sir.
a mild pH.
Mild pH.
When it
Moderate-
is more than A2 in pulmonary area, it's a moderate pH.
And one is
And when it is
banging. It is
When
No,
it is heard
in
outside
apical.
pulmonary area,
Okay,
it
sir.
is a
Okay, sir.
severe pH.
Severe pH.
That is a classical definition of pH according to auscultatory finding.
Yes.
Even if they are associated with gum still murmur, what will be the level of pH?
That is severe pH, sir.
Yes.
How much? It's suprasystemic.
Okay, sir. Suprasystemic.
Right. So your diagnosis with NOHA class 3 is not tenable, na?
Yes, sir.
Right.
This maybe NHA class 2, your question.
Okay, sir.
The second important thing, how you are telling it's a dynamic LVOT obstruction.
Sir, I am telling, sir, the dynamic LVOT obstruction because inside the murmur is behaving like a dynamic LVOT obstruction lesion.
Yeah. What do you mean by dynamic LVOT obstruction?
So dynamic LVOT obstruction means that during the period of systole, in early systole period, the obstruction is minimal, and in mid to late systole, the obstruction is maximal.
Or second important thing?
Another important thing is, sir, obstruction is dependent on LV volume. If LV volume is less, then obstruction will increase.
Good. Matlab the obstruction will vary
Vary,
depending
sir.
upon many other things.
Yes, sir. Depending on preload and
That's why
afterload.
sometimes you get a very short murmur, sometimes prolonged murmur.
Yes, sir.
What happens when you take hot bath to this murmur?
Sir, the murmur will increase, sir.
Kyun?
Sir, hot bath will cause peripheral vasodilatation, and afterload will
Very-
decrease, the gradient will
Very
increase,
good.
sir.
Very good. That is a mechanism in TOF, in cyanotic spell. When
Yes,
you
sir.
take hot bath, patient may go into cyanotic spell. Very good. It's cause
Yes.
a peripheral vasodilatation.
Yes, sir.
How can you say this is a sinus rhythm? on clinical examination? It may be a junctional rhythm.
Sir,
It may be a slow VT. It may be ectopic atrial tachycardia. How can you say that this is a sinus rhythm on clinical examination?
Clinical examination. So can you say anything from
sir, in sinus
hints?
arrhythmia will be there in sinus rhythm. The
May not be
respiratory
there?
may vary with expression and inspiration. And in case of
Children,
junctional
this is
or
children.
slow VT, this will be absent.
चलो एक तुम्हारा मान लिया, क्लिनिकली कैसे बताओगे कि साइनस है? अगर साइनस एरिथमिया बहुत प्रोमिनेंट नहीं है तो
नहीं, एडल्ट में उतना प्रोमिनेंट नहीं होता है सर,
हाँ,
बच्चों
तो-
में प्रोमिनेंट होता है
अरे क्या क्या
ज्यादा।
फीचर मिलेंगे जो इनडायरेक्टली सजेस्ट की इट इज अ साइनस रिदम?
Sir, it will be corroborate with apical beat. It will corroborate with heart sound.
नहीं नहीं, क्या होता है? जेवीपी से शुरू करो.
Clue is there. Only in JVP you can differentiate.
Exactly.
Okay, sir. It will corroborate with JVP, sir, V wave.
नहीं,
नहीं देखो,
जेवीपी
Sin-
विल हैव
what doc is asking, this can be sinus, this can be junctional.
Yes,
So from the JVP itself, you can
Yes,
say
junctional side, it will have Canon A waves or
yes.
large
So-
A waves, sir.
yes.
Yes.
So regularly, if you see A and V, that is correlated,
Yes.
then
Yes.
क्या होगा जंक्शन में और क्या क्या फाइंडिंग मिलेगी?
और क्या होगा junctional में?
Suppose there is a sinus suppressor, it will be a intermittent canyon wave you can find, or auscultation में
So auscultation में loud S1 हो सकता है सर.
नहीं, क्या बोलते हैं उसको? लाउड बोलते हैं.
और variability क्या होता है?
सीएचबी में क्या स्पन मिलता है? It will be both intensity. It is a variable first heart sound.
Okay, sir.
So sometimes it may be loud, sometimes this dull.
Okay, sir.
So yeah. So that is why, because JBP is very important. JBP gives much clue, because you see, when ECG were not there, at that time also blocks were diagnosed by seeing JBP by our earlier scientists, our physicians
Yes, sir.
at that time.
फर्स्ट डिग्री एवी ब्लॉक जेवीपी से कैसे पता लगाओगे?
Sir,
क्या होता है?
first degree AV block, sir.
तो सर कह रहे हैं पुराने लोग जो थे ना,
हाँ,
ये
sir.
सब इनडायरेक्टली बता देते थे जेवीपी देख
Ah.
के.
So, sir, how do you see A wave and C wave in
The-
GVP?
Yes, sir. The wave that is coming with carotid upstroke is C wave, sir. And the
Huh?
positive of
नहीं,
A wave?
the C wave comes with carotid upstroke.
Yes,
हाँ,
yes.
वी वेव
V wave comes, sir, and the positive reflection before that will be A wave.
नहीं तो
Yes.
क्या होता है? कैसे कहते हो? कैरोटिड, you feel carotid and you
Exactly.
JVP. So what happened to A wave? What happened to
V wave.
V
V
wave.
wave?
So V will come after that. And
Recording in progress.
Enumerate the causes of regular rhythm and
Uh,
irregularly irregular rhythm. Just enumerate two causes. What is
okay, sir. First, sir, regular rhythm, sir. One is uh, uh, normal sinus rhythm.
Yes,
Complete heart block will
Yes.
come regularly. Junctional
Yes.
rhythm will come regularly.
or
The slow ventricular tachycardia will come regularly. And sir,
all
in
full है.
Atrial flutter with fixed block?
atrial flutter is fixed block. Yes, sir.
हाँ,
Yes, sir. And sir, in case of irregular, we have, sir, atrial fibrillation
Yes.
We have multifocal atrial tachycardia.
दो,
Sir, atrial flutter with variable block.
3,
And sir, we have multifocal PVCs.
multifocal
PVCs.
और एक और भूल गए, जस्ट टेल वन मोर. दो और बचे हैं, अभी तो 4 बोले. वॉन्डरिंग पेसमेकर
Wandering atrial pacemaker. Yes, sir.
एंड मल्टीफोकल एट्रियल tachycardia.
Sir, that I said
Yes.
in second.
अच्छा ठीक.
Okay,
Wandering
sir.
pacemaker is one of the cause.
Yes, yes, the wandering pacemaker. Yes, sir.
So what are the different types of sinus arrhythmia?
It's a type of sinus arrhythmia, sir.
Not some sinus arrhythmia, na?
Yes, sir.
One is respiratory, one is non-respiratory,
Yes, sir.
one is ventriculophasic.
Okay, sir.
Read all these things. Right.
Yes, sir. Yes, sir. I will read it better, sir.
Sure.
I think we'll go for investigations.
Right. Go.
Hello.
Yes, sir.
Yes, yes.
Yes.
Hello. Am I audible?
Yes. Yes.
Thank you, sir. So first coming on to ECG. ECG. Here ECG shows normal sinus rhythm with normal axis within 15 to 30 degree range, and there is symmetric T wave inversion seen in V4 to V6 and inferior leads in lead 2 and AVF. And there is a features of left ventricular hypertrophy. Next,
Next.
this is chest X-ray of the patient showing cardiothoracic ratio within normal limit.
Then.
Now,
Like
this
chest
is
X-ray. Chest X-ray. Show also
the
the chest X-ray.
chest X-ray. There is no cardiomegaly. CT ratio is within normal limit.
But what are those visible venous? Yeah. The
I
upper
think
lobes.
we'll go back to ECG. What are the findings in ECG?
Sir, in
You told
ECG,
axis is 15 to 30.
yes, sir.
Why are you telling 15 to 30?
Sir, at
What is the maximum I mean,
The maximum deflection is
sir, maximum deflection is lead 2.
2. So
Lead to
axis will be parallel to lead 2.
you are telling just opposite. Isn't it?
Yes.
What else are there?
Sir, there is symmetric T wave inversion in lead V4 to V6 and lead 2 AVF 1 AVL, and there is also a biphasic T in lead 3.
This may be due to what? This
Sir, the pattern of ECG is typical of apical HCM.
apical SCM. Why not ischemic? This figure, why not ischemic?
Sir, the ST segment is more or less normal, and the T wave inversion is symmetrical, sir.
Yeah.
Wave inversion. Both the limbs are similar, same.
Yes.
There is also there, no? It is
Yes,
also
sir.
there here.
तुमने P wave पे कमेंट नहीं किया, P wave पे.
E wave, right?
Sir, P wave, say amplitude, sir, amplitude is 2 mm and duration is about 0.08 seconds, sir.
तो क्या है? लीड V1 में क्या है?
Sorry, in lead wave there is inverted P wave.
ये क्या है? What it denotes?
Suggests.
Sir, it denotes sir increased left atrial force.
LA
पहले enlargement है कि नहीं है?
Sir,
Yes, it is there.
yes, sir, sir. It is there, sir.
So when there is a LA enlargement, what other you should suspect in heart? You should
Sir,
suspect कि MR हो सकता है.
yes, yes, sir.
So the MR of HOCM, how the murmur of MR of HOCM is different from other MR.
Sir, murmur, MR, HOCM, MR murmur is more like holosystolic murmur.
Right?
कहाँ MR होता है? क्या बोला तुमने? When MR start?
MR, MR will sorry, sir, MR will start. It will be posteriorly directed and it will start up mid to late systole.
हाँ, it how
Right.
can be जब तक SAM नहीं होगा MR
Yes,
नहीं
sir.
होगा. And
And
if
how
there
can
is
be
a
holosystolic?
pansystolic MR in SCM, what it denotes?
See, it may be due to other pathology, may be associated with MVP or
No, MVP का murmur is not pansystolic.
no, associated with
Suppose
other
in
etiology.
HOCM, just ask question. If in HOCM you are getting a pansystolic MR murmur versus missed systolic MR murmur, what is more grave?
Sir, it may be an acute murmur due to body rupture.
No,
No. Again, there is a short murmur. Body rupture.
long murmur denotes what? Pansystolic. The mitral valve has already been distorted.
Okay, sir.
So you are going to require MVR along with surgery.
Exactly.
Okay, sir.
So if it's a pansystolic murmur, usually surgery is the option. So you can differentiate that it is because of SAM or it is because of mitral valve disease.
Mitral valve pathology.
Okay, go to the X-ray.
Yes, sir. Sir,
What you are finding? Yes.
sir, chest X-ray, in our X-ray, it does not show any cardiomegaly.
What are those? Upper lobar venous diversion.
And so there is upper lobar venous direction, pulmonary venous hypertension may
Yes.
be present in
You are not
this
commenting on
X-ray.
that. Why do you say it is upper? When you say it is upper lobar venous diversion?
What about RA? What about aortic shadow? Is there an RA enlargement?
No, sir.
How you say there is RA enlargement in the X-ray?
Sir, in case of RA enlargement, there may be a double contour shape.
No. That is your LA. RA enlargement I am asking.
Sir, RA shadow may be present in third intercostal space.
Gone. You have not read about RA enlargement.
Ah,
It occupies more than 2.5 space.
yes, exactly.
In the outer border of the RA may be 5 centimeter or 5.5 centimeter from
From
the
the central line.
center.
Oh.
From the center, you have to draw a line, vertical line,
Okay, sir.
and draw to the maximum RA border. Right. And it occupies more than spaces.
2.5 intercostal space. Here it occupies almost 3 intercostal space in your patient.
Right.
And this aortic shadow. You can see the aortic shadow.
Yes,
Is
sir.
the
Knuckle you are seeing?
Is the ascending aorta dilated? To us, you know the X-ray better, but it appears ascending aorta and aortic knuckle both are seen. Aortic ascending aorta seems to be little dilated.
Sir, maybe little dilated, sir.
Are you able
Can
to
it
see the
occur?
ascending aortic shadow?
Can it occur in the hypertrophic obstructive cardiomyopathy?
Will it occur?
Still occur if there is hypertension and other
Sir,
comorbid.
if there is concomitant hypertension,
Exactly.
then it may occur.
Yes, sir. Otherwise it cannot. Say on that. That is You have to answer like that, no?
Yes.
Good.
Yeah, there is ascending aorta dilatation, which is more common. AS, AR, hypertrophic cardiomyopathy. Which one?
Say AR.
Air is air occur both ascending aorta, also the other part of the aorta. But there can be ascending aortic dilatation in valvular aortic stenosis. Okay. Okay, go to the next.
Sir, this is an echocardiography showing parasternal long axis view showing left atrium, left ventricle, aorta, and RVOT. Here we can see that aortic root diameter is 31 mm and LA dimension is 51 mm. And we can clearly see the presence of hypertrophic interventricular septum in the next view, and this is the M mode echocardiography along the anterior mitral leaflet. And here we can distinctly show that a anterior mitral leaflet touches the septum at systole, and there is presence of grade 3 SAM.
This is only a static picture you have got, or a video is there?
No, sir, it is static picture.
Okay. Okay. Okay, what else is there? Yes.
Sir, after measurement, the interventricular septum is about 25 mm, posterior wall is 15 mm, and left ventricular diameter in diastole is 53 and in systole is 32. And on calculation, EF is about 68%.
Okay.
Left ventricular endoscopic diameter is
Sir, 53.
53. It's touching the upper limit of the normal, na?
Yes, sir.
So there is asymmetrical septal hypertrophy.
Yes, sir. There is asymmetrical septal hypertrophy.
And there is sham.
Yes, sir.
LV function is normal. Okay. LV is not dilated, just upper border.
Just a borderline.
Okay. Next.
Sir, this sir, this is just a CW image. There is no significant mid cavity obstruction, and the shape of the the next slide shows there is significant LVOT obstruction, and in continuous wave Doppler the gradient is 54 mmHg at resting state.
Shape. There is a definite shape. What is called?
It's a dagger shaped.
It is there. Right.
Right. Next. Yes. Can I go back? Go back. Yeah. So what Dr. Ganguly was asking, how do you differentiate from this? This is due to hypertrophy of aortic cardiomyopathy or due to aortic stenosis?
Sir, the typical dagger shaped occurrence is due to HOCM, and there is a distinct implicit point after which suggests at the time where the velocity is lowest at 1.5 to 2.5 meter per second, and after that the the obstruction there is a fixed concave leftward shaped till the maximum gradient, and after that it touches baseline with convex leftward shape. And in case of AS, there will be no such inflection point, and the dagger shape will not occur.
That we will find in the 2D image.
Yes. 2D image we can just show, we can see the morphological shape of the septum.
Okay.
And in our case, I think it may be a reverse septum pattern.
Any speckled appearance or anything?
Yes.
Yes, sir.
The hypertrophic septum and ventricular wall, you can see the spicules.
Yes. Yes, sir. And also, sir, we can see the aortic valve morphology in 2D image.
So in your case, it is not there. Okay, continue.
Is this?
Hello.
Yes.
Hello?
Hello, sir. This is the strain imaging of the patient, then
Ah.
showing by LV biplane ejection fraction is about 52%. Next.
In this view, what you are seeing?
Yes, sir.
In this view, what
Hmm.
you are seeing?
Sir, there is ejection fraction is 52% around, and there is less. There is the strain is lesser in anteroseptal and septal portion, which is denoted by the fading nature of the color.
Right. What is the GLS?
The global longitudinal strain is 52%.
Right.
52.
What have you written?
It is normal.
Ah.
No, sir. Actually, it should increase, but we found that it is about 52%. It suggests that there may be some sort of fibrosis in the anteroseptal or septal portion, which are already occurred.
No, you are
Fibrosis?
not. You are seeing GLS written how much? 16, 17, 13, 15 like this.
Yes. Below 15, it is low. Yes, we say like that.
Okay, sir.
What is the normal GLS? Normal?
Yes.
Say 15 to 25.
Yes, exactly. But you are saying, don't express it as 52%, huh?
But you have probably told the EF from the strain echo, not GLS. That 52 data, I think.
Exactly. 52 is the
Oh, that
ejection
is
fraction.
different. I think that data that is written in the side, that has been calculated, it has come. And the picture is showing actually the apical area.
Yes, sir.
Yes. The GLS will not be 52. It is probably you have got the EF from that strain echo. That is around 52. Okay.
Yeah, that is different, correct. Huh? So it is,
GLS is expressed like that, 15, 18, something like that.
yes.
Right. Below 15, slow, and suggests will be dysfunction.
Yes, sir.
Okay.
So other investigation, we perform 24-hour Holter monitoring, which shows
But
few
what,
ventricular
how
and
MRI
supraventricular ectopic, but there is no significant AV block or no runs of any NSVT or VT.
So you could not 24 hours.
Yes, sir.
You may not get NSVT or VT in 24 hours.
Yes, sir. And extended Holter is suggested.
Yes. So what will happen? What will you get in MRI?
Sir, in MRI, we corroborate the findings of echo, and the most important is late gadolinium enhancement and scar burden. It is the most important thing.
See have you done MRI, CMR in this case?
No, sir, we cannot
Sir,
perform.
CMR was planned, sir, but actually the patient took discharge because of some puja in his house.
Sir, right.
Yes, sir.
Yes, you should do it. And what do you want to see?
Sir,
Sir,
in case of CMR is actually better than echocardiography to delineate wall thickness, the LVOT gradient, accurately measure the ejection fraction, and also we can see the scar burden and late gadolinium enhancement. If it is more than 15%, then it is a marker for sudden cardiac death.
Exactly. Right.
Right,
That is
right.
important to us, no?
Yes, sir. It is most important, sir.
Okay. What other investigation you have done?
Sir, we could not perform any more investigation because
Okay.
patient took discharge,
From
sir.
this much of investigation, how will you prognosticate this case? What are the prognostic parameters? What we must look for and what
Yes,
you,
sir.
yes, in your case.
Yes, sir. First of all, from history, we should look for if there is any history of family history of sudden cardiac death in first degree relatives or multiple history of sudden cardiac death in second degree relatives. Second, sir, we should inquire about some history of unexplained syncope that is not attributable to any neurocardiogenic syncope or something like that. Then, sir, in examination, we should look for LV wall thickness, the late gadolinium enhancement pattern, the ejection fraction.
No, no,
every-
what is the recommended? No, no. What is the guideline says? You cannot go haphazardly. There is a clear-cut recent guideline came.
Sir, in ACCHA 2020 guidelines, 7 things are written as the classical features of sudden cardiac death. One is family history of sudden cardiac death. Second
Yeah.
is history of unexplained syncope. Third is left ventricular enlargement more than 30 millimeter mercury. Fourth
Oh.
one is the ejection fraction less than 50%. Then LV apical aneurysm. Then, sir, NSBT, which are NSBT, and third is seventh is LGE.
LG is still included or not?
Sir, in ACCAHA, it is included, sir.
What is the scoring? अभी recent
Sir, scoring is, sir, ESC में आया है scoring,
Yes,
sir.
yes,
Complicated
yes,
recently
logarithmic
आया.
scoring is there. It includes left atrial size, LV outflow obstruction, but it has omitted LGE, sir.
right.
So in your case,
Sir,
what will
sir,
So, have you read recently ACCHA guideline for hypertrophic cardiomyopathy? Only few months back. What is new there? Okay, hold on. We should complete. Carry on.
sir, this is last size, sir.
oh, this
Finish.
is your last. So what are the genetic basis? What are genetic?
Yes, sir. Sir, coming to genetics, sir, among the sporadic cases, 30% may be attributable to sarcomeric gene mutation of pathogenic variants, and in sporadic cases, 30%, in familial cases, 60% cases may be attributable. Among such sarcomeric gene mutations, MYH7 and MYC BP3, those two genes are responsible for almost 80 to 90%, 80% of cases of HCM. And sir, in case of troponin T mutation, hypertrophy may be not so significant, but sudden cardiac death risk is maximal with TNN T2 mutation.
So troponin T and troponin C mutation also shows high certain cardiac
Yes, sir.
death.
Yes, sir. High burden of sudden cardiac death, sir.
What occurs in this? I mean, pathological changes occur.
Sir, pathological changes occur, sir. There is myocyte disarray, hypertrophy, and fibrosis. That proves needus for re-entry circuit and causes scar and VT, sir. That causes sudden cardiac death.
Yeah. So that looks like speckled appearance in their 2D echo, also in MRI. If the
Yes,
speckled, yes, it is more than 20%, then there is a high chance.
Yes, sir.
Then this, what are the management? How will you manage such case? What are the recent treatment that has come?
Sir, first of all, first management is counseling. One is we should offer genetic counseling and genetic testing and also prognostication. Second is symptomatic management. And third is ICD risk, sudden cardiac death risk assessment and evaluation for ICD insertion. There are three lines of management.
I have to tell what is medical management.
Sir, medical management, first line is, sir, beta blocker. Second, sir, is non-dihydropyridine calcium channel blocker. If those symptoms cannot persist, then disopyramide may be added. And sir, in recent times, mavacamten has come out, sir.
So
How good
it is a
Yes.
stepwise approach or alternative approach?
Sir, beta blocker and calcium channel blocker, those are alternative. And
Dose. What is the dose?
So
Beta blocker in which condition? Calcium channel blocker in which condition is a drug of choice?
sir, beta blocker when there is a tachycardia, then beta blocker is a drug of choice. And when sir ejection fraction is near no normal region, then sir beta blocker is of choice. We cannot use verapamil in those conditions, sir.
What do you mean by LVOT obstruction?
Sir, LVOT obstruction, sir, when resting gradient is more than 30 millimeter of mercury.
Which is preferred, calcium channel blocker or beta blocker?
Sir, calcium channel blocker is preferred, sir, in this insignificant LVOT obstruction.
With the gradient, peak gradient, mean gradient in this case.
Sir, peak gradient is 54 millimeter of mercury.
Mean?
Sir, mean I have not measured because mean is not. Yes, sir. Mean is
Have you
not
done
truly.
and coronary angio?
So coronary angio should be performed, sir, in this case.
You have not done a patient?
Yes, yes, sir,
By
yes,
that
sir.
time, na?
Yes, sir.
Is it
He will
important?
again be admitted, sir.
Is it
So there is,
important?
Sir?
so there is significant LVOT gradient.
Yes, sir.
In this case, how will you manage?
Sir, in this case, patient would be put on, sir, calcium channel blocker and will be assessed for symptomatic improvement first.
In spite of that, patient is symptomatic.
Then, sir, we can add disopyramide along with calcium channel blocker.
But others, you think no, septal ablation, you know,
Sir,
What I'm asking,
Sir, septal reduction therapy should be prescribed in medical management failure patient when symptoms are debilitating and not properly controlled with medical management.
What, myomectomy or TASH? Which is preferred?
Sir, in experience centers, sir, myectomy is always preferred than alcoholic septal ablation.
Why?
Sir, because preoperative, perioperative mortality is less, there is no virtually no chance of recurrence. Then multiple issues can be addressed at one time. Mitral valve morphological as issue, mitral valve aortic morphology issue, and there is also there is very little chance for complete heart block and recurrent VT or VF, sir.
So actually, earlier myectomy has been established procedure.
Yes, sir.
And the definite benefits are there, you are telling. But at present context, in the experience hand, septal ablation is also equally.
Yes, sir. So, NOIHA class improvement is similar in both the groups.
And here you are not going to go open heart surgery because open heart surgery complications are there with the septal myectomy.
Yes, sir. Yes, sir.
But you are correct. The current guidelines prefer myomectomy over septal ablation. That is
right.
true.
That will have to tell.
That is true.
Actually, myomectomy is preferred in the younger
patients, yes, younger,
and septal ablation in the older patients.
Yes, sir. And right? also, sir, in patients whose gradient is more than 100 millimeter of mercury and LV thickness is very much, then myectomy is preferred over septal ablation.
When it cannot be done.
Yes, sir. Yes, sir. Yes.
When it cannot be done.
Sir, myectomy. Sir, in case of RBV, myectomy cannot be done.
Sorry, telling when myectomy cannot be done, you can go for a septal ablation. That is.
Yes, sir. Sir, in case of very frail patients, in case of high surgical risk, and in patients presenting with right bundle branch block, we cannot do myectomy.
Exactly.
Yes,
and what do you do in that septal ablation?
Sir, in septal ablation, we first cannulate us first septal perforator, then we septal perforator artery, sir, LED from branch, first or second septal. Septal branch. Septal branch.
Which, not perforator. Which branch?
Sir, first or second?
You the largest one.
Largest.
How will you know that this is the branch supplies the LVOT?
Sir,
how will you know?
Sir, after sir OTW balloon, we will inject some agitated saline, sir, and we will look in the echocardiography that which part of septum is getting affected.
Is that contrast echo?
Yes, sir, contrast echo, sir.
Or
sir, sonicated albumin, we can use contrast echo.
No. What you can do with that balloon, you occlude that branch.
Okay,
see the gradient.
Okay, sir. Okay, sir. Myocardial stunning gradient will decrease immediately.
Yes.
Yes.
Right. Then.
Then, sir, we will inject absolute alcohol 1 to 3 ml maximum. Then we will look for the symptoms and ST elevation in V1. And the gradients are immediately will decrease because of myocardial stunning. But in long run, it may take up to 3 months for gradient to decrease via remodeling.
For alcohol, must give morphine to this patient, number 1.
Yes.
And you must have a temporary
pacemaker ready, inserted. Yes, sir.
Ready, not ready.
Inserted. Yes, sir. And it should be kept for 48 hours to see. Yes, sir.
What about yes, mavacamten and other drugs?
How it acts, mavacamten?
Sir, it is a selective cardiac myosin ATPase inhibitor.
How it acts?
Sir, it inhibits myosin ATPase, so it helps in relaxation, contractility, and myocardial energetics is beneficially affected.
Captain Mackerville also acts on this. What is the difference?
Sir, omecamtiv mecarbil is myosin inhibitor, sir. Direct.
So, what is the difference? Acts in active myosin conjugation. More.
Okay, sir.
Reverse is this mavacamten.
Okay, sir. Okay, sir.
What are the contraindications of mavacamten?
Sir, low ejection fraction because it
And?
decreases, sir, cardiac contractility. Sir, currently mavacamten is not used in conjunction in NYHA class 4 patients with fluid heart failure. So it should be used in caution.
Right. So you tell me, your case is syndromic or non-syndromic HCM?
Sir, from general survey, sir, it is non-syndromic, and age of presentation, it is non-syndromic, sir.
What are the syndromics? HCM?
Yes, sir. Sir,
what are those?
Sir, those are, sir, first Danon disease, which is LAMP gene mutation. One is Fabry's disease, acid alpha glucosidase. One is PRKG2 mutation. One is, sir, Noonan and other rasopathies like, sir, PTPN G1 mutation or RAF1 mutation. One is, sir, Friedreich's ataxia, frataxin gene mutation, and
Right.
also, sir, amyloidosis, TTR gene mutation.
What is Lupert syndrome?
Sir, Lupert syndrome, sir, RAF1 gene mutation, sir, RAF1 gene
What are the
mutation.
components?
Sir, components, sir, mental retardation, skin neurological and renal manifestation, along with pre-excitation and hypertrophic cardiomyopathy.
No pre-excitation. Bundle
Okay.
for blood. There is conduction system for block.
Oh, block.
Deafness.
Yes, in block. The pre-excitation in case of, sir, Danon and PRKGA2 mutation. Yes, sir.
What about
Natural
the
history of- yes. Yes, Dr. Rao, carry on.
what about the inheritance? It is autosomal recessive,
Sir,
dominant.
sir, it is an autosomal dominant with variable expressivity and variable penetrance.
So, say if the one of the father is having SCM, what is
Yes,
the
sir.
chances of getting SCM in the offspring?
Sir, gene will be transmitted 50% chance, but sir, whether the gene will express or not, and if it is expresses, whether the symptoms will be severe or not, that is, sir, not decided because of variable penetrance and variable expressivity.
Right.
That is why longitudinal screening is recommended, sir, every 1 to 2 years.
So now in Western countries, they have gone for screening, and after screening and detecting all these things, the chances of sudden cardiac death has decreased because
Yes,
these usually they have found their prevalence of SCM are localized in geographic distributions.
Okay, sir.
And yeah, they have gone for screening. So screening is again important because in India it is not possible, but at least the families should be screened.
Yes, sir.
And fast
How it
and
is possible in Delhi? In Delhi, they are doing. Genetics testing is doing, yes, for these cardiomyopathies. 27,000 they are charging. They are doing.
Oh yes. Dr. Lal Patulab has also come up with a genetic screening of all the things there.
Yes.
So, yeah. So actually, this is required because if there is familial, there should be screened. Though family of sudden cardiac death, there is other persons they must be screened because by this you can prevent sudden cardiac death in these patients.
Yes,
and so what are the natural history?
Exactly. I was going to ask. What is the natural history of HCM?
Sir, natural history is, sir, mortality is earlier it was 4 to 6% per year. Now it is 1% per year. And after the
normal life is possible.
Yes, sir, possible, sir. After 60 years of age, the chance of sudden cardiac death is, yes, sir, sudden cardiac death is very less, and after that, the chance of heart failure rises.
Correct. So then developing dilated cardiomyopathy, hypertension.
Yes, sir. Burnt out HCM, dilated cardiomyopathy.
What are the other risk factors? Apart from your cardiac, what you have just told.
Yes, sir.
Sickness, What are other risk factors?
Sir, development of atrial fibrillation is very detrimental in these patients, sir.
Others, one is diabetes, one is hypertension,
Yes,
one
sir.
is sleep apnea,
Okay,
and
yes.
there is stroke.
Yes, sir. Yes, sir. Stroke.
Right.
So Dr. Rakesh, any other question?
Yes, sir, I'm listening. ठीक है.
I think okay. So last question is of cardiac transplant.
Sir, in burnt out cases, there may be tried for cardiac transplant, and in Western countries, it is being performed, sir.
Yeah, in Western countries, if all these things fail, in spite of that patient is symptomatic, having arrhythmia and going to heart failure.
Almost 300 plus students have joined.
Okay, okay.
Very encouraging. And we had beautiful discussion. Recently, there is, as I told you, there is a publication by ACCHA, the guidelines. They have subdivided into genotype, phenotype, all those things. And genotype, how you treat, all those newer things are there. Read it.
Yes, sir. Yes, sir. Definitely, sir.
So my last comment is, usually this is given as a short case in your examination.
Exactly.
And whatever question we have asked, only 99% chance you will be only asked these questions.
Yes,
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 sir.
yes.
Yes, sir.
So if you can prepare, you can note it down. I
Yes,
think
sir.
not anything more will be asked from you in your examination.
Yes, sir.
So
Yes,
if you have
Okay,
prepared like this, I think your one short case is prepared.
yes, sir.
Yes.
sir. Thank you, sir. Thank you.
thank you,
It's
sir.
like this. So, thank you.
Thank you.
Dr.
Thank you.
Rakesh Jadhav.
you.
Thank you,
Thank
Dr.
you, sir.
Raut Rai. Thank you, Dr. Bishwajit
Thank you, sir.
Majumdar, and
Okay.
our students.
Yes, yes.
Somnath.
Yeah.
You have
They have
done
done,
good.
yeah, they have done good.
Thank you.
Yes,
Yes, you have
Thank
done
you, sir.
good.
They're a little nervous. And clinical part they have to improve, because what I find, students, two things you lack. You lack in JVP and second heart sound. This thing, you'll have to very thorough in JVP and second heart sound.
Yes,
That
sir.
gives
Right.
much clue, and that helps in assessing your case, how you differentiate, and all the things required.
Yes,
To
sir.
give more importance to clinical.
Sure, sir. Sure, sir. Thank you, sir.
Okay. 13th to 15th September, we shall have physical meet. Expect all of you. I shall invite you, especially.
Okay.
Thank you, sir. Thank you, sir.
Thank you.
With this, conclude this session. Thank you, Raut Rai, Dr. Jadhav, and our students, Ritam and Shamnath. We shall have discussions on like this in future also. Thank you.
Thank you.
Thank you. Thank you.